Bismillahirrahmanirrahim. Knowledge is not what is memorized. Knowledge is what benefits. Assalamu alaikum, everyone. My name is Dr. MOMENA. I am a PGR in Community Medicine Department, and I'm today here presenting the topic of estimation of potential of prevention under kind supervision of my supervisor, Professor Dr. Saira. Learning outlines will be introduction, a brief overview of types of prevention. Then we're going to move on to importance, key concepts, and methods of estimation of prevention potential. Then there will be certain examples and challenges in estimation, and at the end, recent advances, MCQs with key. Learning objectives will be by the end of this presentation, participants will be able to understand the potential of prevention in terms of attributable risk, population attributable fraction, number needed to treat, and impact fraction. Introduction. Epidemiology. The study of the distribution and determinants of health-related states or events in a population is known as epidemiology. Now, what is prevention in epidemiology? These are the measures to prevent a disease or injury, including primary, secondary, and tertiary prevention. Estimation of potential for prevention. The process of assessing the effectiveness and scope of preventive interventions in reducing disease burden constitute estimation of potential for prevention. We're going to have a brief overview of types of prevention. Primordial prevention. These are the actions that are aimed at preventing the development of risk factors for disease before they even emerge. Examples include policies to improve the air quality, reducing exposure to pollutants like tobacco smoke, and promoting cleaner environments to prevent the respiratory diseases. Primary prevention. These aim to prevent the occurrence of diseases. Example, vaccination programs and lifestyle changes. Secondary prevention aims to detect the disease early and reduce the severity. It includes the screening programs. Tertiary prevention aims to reduce the impact of a disease and prevent its further complications. It includes the rehab. This is the diagrammatic representation of the actions that are taken at each of the levels. In case of primordial prevention, the public health interventions are taken at societal level, which affect the system and determine the risk factors of a disease so that the risk factors may not appear. Moving on to primary prevention, detection and management of the risk factors for future disease. And these are the interventions that are done at a person level. Secondary prevention, screening for asymptomatic early disease, and tertiary prevention, improved management of patients with established disease. Here is another view which shows the levels of prevention along with the interventions that are included at each level. In case of the primordial prevention, individual education and mass education is required. In case of primary prevention, health promotion, specific protection is done. And early diagnosis, prompt treatment comes under the heading of secondary prevention. Similarly, disability limitation and rehab comes under the heading of tertiary prevention. Let's have a quick example for the overview of the primary, secondary, and tertiary preventions. So this is the primary prevalence examples of risk and protective factors for those at risk for developing opioid use disorder. So it's taken from a research. It shows the risks at the individual level and interpersonal level and macro level being the environment. So at individual level, adverse childhood experiences, trauma and stress. At interpersonal levels, lack of consistent caring adult during childhood, in utero exposure to maternal stress. In case of the macro, community disinvestment and poverty, insufficient insurance coverage for mental health and medical services. So what are the primary prevention factors that we can do to avoid this? At individual level, schools and out of school programs that support youth achievement of age appropriate milestones. In case of the interpersonal level, stress buffering, like factors that mitigate the stress, sufficient provider capacity and reimbursement, social support, investments and evidence-based prevention in and out of school time, and promotion of parental and intergenerational health. At macro level, community vitality and economic opportunities and support for resource-limited families and individuals should be considered. Similarly, the secondary prevention examples of risk and protective factors for those with opioid use disorder. So similarly, the risks at individual levels are co-occurring mental health conditions and other comorbs, internalization of stigma due to the drug use and discrimination. At interpersonal levels, stigma against people with SUD, social isolation, insufficient provider capacity, and at macro level, societal stigma and discrimination, lack of addiction content in medical and mental health training. So, what are the protective factors which can provide the secondary prevention against these risk factors? These are the initiation of and retention in medication for opioid use disorder treatment, receipt of early diagnosis, basic needs met, self-actualization, stable housing. At interpersonal level, peer recovery, support, and other interpersonal surface retention. And at macro level, housing and workplace policies, access to case management and other supportive services, availability of addiction consultation. Tertiary prevention, risks, forced withdrawal during recent incarceration, collateral consequences of incarceration on individual societal determinants. In case of interpersonal level, stigma against people with substance abuse disorder, and macro societal stigma and discrimination. So the protective factors would be overdose prevention knowledges, co-prescribing of Nexalon along with medication is elevated risk profiles for substance abuse disorder, and availability of overdose education and naloxone programs. Let's move on to the importance of estimation in epidemiology. This highlights why the estimation of prevention potential is important and why it should be done. So it is a critical component of public health research and planning because it helps in understanding the effectiveness of interventions and in prioritizing resources of disease prevention. Here are some of the key reasons why the estimation of preventive potential is important in epidemiology. Number one is resource allocation. Identifying the most effective intervention helps in efficient allocation of limited healthcare resources. Number two is health policy development. It provides evidence for policymakers to prioritize the public health initiative. Disease burden reduction. It helps in quantifying how much disease burden can be reduced by preventive measures. Some of the other importance are guiding public health policy and interventions, which comes under the same heading of public policy generation, and setting priorities for disease control, as some diseases may have a high burden but are preventable through cost-effective measures. Estimating the preventive potential of interventions for these diseases allows public health authorities to set priorities for disease control programs. Improving health outcomes, also the assessment of population level impact of a disease, evaluating the effectiveness of current interventions, supporting evidence-based medicine, and identifying the risk factors and enhancing surveillance systems. Now, what are the key concepts in estimating the prevention potential? Number one is attributable risk, which is a measures the proportion of a disease that can be attributed to a risk factor. It is a key concept in epidemiology that helps quantify the contribution of a specific exposure or risk factor to the overall incidence of a disease in a population. It refers to the proportion of the disease incidence in the exposed group that can be attributed to the exposure itself as opposed to other factors. Attributable risk can be thought of as the excess risk of disease among those who are exposed compared to those who are not exposed. It provides a measure of how much of the disease burden in the exposed population is due to the specific risk factor under study. How we're going to calculate an attributable risk? So it is the difference in the incidence of the disease between the exposed, that is IE, and unexposed, that is IU. Where IE is the incidence rates of disease in the exposed group, IU is the incidence rate of disease in the unexposed group. So this formula tells you about how much of the disease risk in the exposed group can be attributed to the exposure itself. There is another term that is attributable risk percentage or proportion. Sometimes it is more informative to express the attributable risk as a percentage of the incidence in the exposed group, which shows how much of the disease risk in the exposed group is due to the exposure. Attributable risk percentage is equals to attributable risk into 100. Attributable risk is equals to incidence in exposed minus incidence in unexposed group. So this is a useful way to communicate the burden of a disease that could potentially be prevented if the exposures were eliminated. Population attributable risk It refers to the proportion of the disease cases in the entire population, both exposed and unexposed individuals, that can be attributed to the exposure. It gives a sense of how much the exposure contributes to the disease burden in a population as a whole. Population attributable risk is calculated as P into E into IE minus IU by I total. This is the formula, where P into E is the proportion of the population that is exposed. I total represents the overall incidence rate of the disease in a population, while the difference of I minus IU is the excess incidence rate due to the exposure. Population attributable risk is important for public health planning and intervention because it shows the overall impact of the exposure on the entire population. Now, what is population attributable risk percentage? So this is also the percentage of the total disease incidence in the population that can be attributed to the exposure. The formula is population attributable risk percentage is equals to population attributable risk into 100, and the population attributable risk formula has been described previously. Now, what is the significance of this attributable risk? Number one is identifying the modifiable risk factors. Example, if the attributable risk of lung cancer due to smoking is high, public health efforts to reduce smoking can have a significant impact on the overall burden of lung cancer, guiding public health interventions. If an exposure like a physical inactivity or poor diet has a high attributable risk for a specific disease, programs targeting that exposure can potentially prevent a large number of cases. Quantifying disease burden. This is particularly useful when attempting to understand the impact of various exposures on public health. Next term is number needed to treat, which is NNT. It is a measure that is used to determine how many patients need to be treated with a specific intervention to prevent one additional adverse outcome. For example, death, disease progression, or heart attack, etc., compared to a control group. So the formula is 1 by absolute risk reduction, where absolute risk reduction is the difference of control event rate and experimental event rate. Now, what is control event rate, or also referred as CER? So the rate at which an adverse event occurs in the control group, those who did not receive the intervention, they are the control event rate, and the experimental event rate, the rate at which an adverse event occurs in the treatment group, those who received the intervention, constitutes the experimental event rate. So there is an inverse relationship between the NNT and the treatment. So a lower NNT indicates that the treatment is more effective at preventing the outcome, as fewer people needs to be treated to prevent one adverse event and vice versa. NNT is often used to communicate the effectiveness of medical interventions and clinical trials, helping doctors and patients weigh the benefits and potential harms of treatment. Next term is impact fraction. Impact fraction, the fraction of the total disease burden that could be avoided through prevention strategies. The impact fraction in epidemiology is a measure that quantifies the proportion of a disease or outcome that could be prevented by eliminating a specific risk factor in a population. It is used to access the preventable fraction of a health outcome attributable to a particular exposure or behavior. Now, what are certain methods that are used in estimation of potential of prevention? So the methods that are used for estimating the potential for prevention in epidemiology depends on the context, including the type of risk factor, the population being studied, and the available data. Quantitative measures like population attributable risk factor, impact fraction, they are valuable tools in assessing the impact of risk factors. Modeling approaches, they can also help estimate potential outcomes under different intervention scenarios. So these methods, they guide public health decision-making and prioritization of prevention strategies to reduce the disease burden in population. Modeling approaches. Epidemiologists sometimes use mathematical and simulation methods to models to estimate the potential for prevention, especially in cases where individual level data or long-term follow-up is unavailable. These models might include cohort models, agent-based models, Markov models. Track the cohort models, they track the group of individuals over time, accounting for risk factors and potential interventions. Agent-based models, they simulate the interactions between individuals and risk factors in a population. And Markov models, they use probabilities to model transitions between health states, for example, from healthy to disease. So there is the table which shows the differences and between different types of modeling. cohort modeling, dynamic transmission modeling, Markov modeling, regression modeling, and system dynamics modeling. So cohort modeling, it uses the data from a cohort of individuals to simulate the impact of the intervention over time. Strengths include estimation of the long-term effects of an intervention, and it's also based on the real-world data. So the challenges are it has large data sets and long-term follow-up, introducing potential bias. It can be best used for estimating the potential prevention of a vaccine or behavioral intervention over time. Moving on to dynamic transmission, models the spreads of infectious diseases within a population and effects of intervention on transmission dynamics. The strengths are it accounts for herd immunity and population level effects of interventions. Challenges are complex to model, especially for diseases with multiple transmission routes or variants or evolving variants. It can be best used for estimating the impact of vaccination campaigns on infectious disease transmission. Markov modeling, it simulates the progression of individuals through different health states, for example, healthy, diseased, or recovered over time. So its strengths include it models the chronic diseases and its effects on long-term health outcomes. But challenges are it requires assumptions about transition probabilities, which may not always be accurate. So it can be best used for evaluating the impact of interventions on diseases with multiple stages like cancer. Moving on to regression model, it uses statistical methods to model the relationship between exposure to a risk factor and the health outcomes. Strengths are it can estimate the relative risks and quantify the effects of interventions on disease outcomes, but it can be sensitive to confounding factors and may not capture the complex interactions. It can be best used for estimating the effectiveness of public health interventions in reducing disease burden. Moving on to system dynamics model, it is a mathematical modeling approach that simulates the feedback loops and interactions between various system components like health, environment, and policy. It captures the dynamic interactions of factors influencing health outcomes, but complex requiring accurate data on many variables and can be computationally intensive. Best use case estimating the long-term effects of public health policies, for example, smoking bans, air quality regulations, etc. Now, screening and early detection effectiveness, it also comes under the heading of methods of estimation. So estimating the potential for prevention is not limited to primary prevention, for example, reducing exposure to risk factors, but also includes secondary prevention through screening and early detection. For example, estimating the reduction in mortality due to early screening for diseases like cancers, for example, mammography for breast cancer, colonoscopy for colorectal cancer. Screening can be evaluated by calculating the numbers needed to screen, the number of individuals who need to be screened to prevent one additional adverse outcome. It has true positive rate and false positive rate, sensitivity and specificity to assess the effectiveness of screening and identifying diseases early. Now, there are certain examples. Example number one is estimation of prevention potential for smoking-related diseases. The risk factor would be smoking. Diseases affected are lung cancer, cardiovascular diseases, respiratory diseases, which involves lungs. Now, what is the population attributable risk factor for lung cancer? It is 85% of lung cancer cases in smokers could potentially be prevented if smoking were eliminated. So what are the interventions? The anti-smoking campaigns, tobacco regulation, smoking cessation programs. The overall impact would be a significant reduction in lung cancer and other related disorders. Example number two is estimation of prevention potential for vaccination. Risk factors, vaccine preventable diseases like measles, polio, hepatitis. Taking measles as an example, 99% of measles cases can be prevented through vaccination. Intervention would be routine immunization programs, and the impact would be reduction in morbidity, mortality, and associated health care costs. Now, what are the challenges? Data limitations, lack of comprehensive data on risk factors, disease burden, and outcomes in some populations, complexity of disease casualty, multiple risk factors. For example, a person may be genetically predisposed to diabetes, but also be exposed to environmental factors like poor diet, lack of exercise, sedentary lifestyle, etc. Synergistic effects. For example, smoking and obesity may interact to dramatically increase the risk of lung cancer or cardiovascular disease. Latent period. Some diseases have long latency periods, for example, cancer or cardiovascular disease, meaning that the effects of exposures may not be seen until many years later. This time lag can complicate efforts to estimate how quickly prevention measures might reduce the disease burden. Certain other challenges are complexity of disease dynamics. Some diseases are influenced by multiple factors, genes, environmental healthcare access, etc. Model assumptions. Assumptions made in mathematical modeling may not always reflect the real world complexities, leading to biases in predictors. What are the approaches for effective estimation? It is the use of surveillance data, like monitoring the prevalence of risk factors and diseases, helps to estimate the effectiveness of prevention strategies, and community engagement. Involving communities in health initiatives can improve the accuracy of estimates and intervention success rates. Integrated data systems, combining data from multiple sources like hospitals, health surveys, public health registries, etc., and can provide a more comprehensive estimates of prevention potential. Sensitivity and uncertainty analysis. Acknowledging and addressing uncertainties in data and models can help improve the reliability of estimates. Effective estimation of prevention potential in a disease, it requires a combination of epidemiological research methods, including cohort studies, RCTs, systematic reviews, modeling techniques, and population surveys. Conclusion. Estimating the potential for prevention, it is crucial in public health as it reduces the burden of disease. Effective estimation methods can guide decision making in resource allocation, policy formulation, and intervention design. While challenges exist, advancements in data collection, modeling techniques, and evidence-based practices continue to improve our ability to accurately estimate the potential for prevention. Recent advances. So this is the article's name. Going from primary to primordial prevention, is the juice worth the squeeze? Published on July 2024. This is the abstract. So while primary prevention strategies target individuals who are at a high risk of cardiovascular disease, there is rising interest towards primordial prevention that focuses on preventing the development of risk factors upstream of disease detection. Therefore, we review the advantages of primordial prevention interventions on minimizing the future cardiovascular events. So the recent findings show primordial prevention of atherosclerotic cardiovascular diseases involves behavioral, genetic, and environmental strategies starting from fetal or infant health and continuing throughout childhood and young adulthood. Early interventions focusing on modifiable risk factors such as physical inactivity, non-ideal body weight, smoking, and environmental pollutants, they are important toward preventing the initial occurrences of risk factors such as hypertension, dyslipidemias, and diabetes to ultimately reduce cardiovascular disease. This is another article, a health impact assessment of an ergonomic measure to reduce the risk of work-related lower back pain, lumbosacral radicular syndrome, and knee osteoarthritis among floor layers in the Netherlands. Published in March 2023. So this is the abstract which shows the Sansamin-bound street floor layers are at a risk of work-related lower back pain, lumbosacral radicular syndrome, and knee osteoarthritis, giving their work techniques of leveling street with their trunk bent while mainly supported by their hands and knees. To reduce the physical demands of bending the trunk and kneeling, a manually movable street leveling machine was developed for floor layers in the Netherlands. The aim of this paper is to estimate the potential health gains of working with a manually movable street leveling machine on the risk of lower back pain, lumbosacral radicular syndrome, and knee osteoarthritis compared to traditional working techniques. This potential health gain was assessed using the epidemiological population estimates of population attributable fraction, which is PAF, and the potential impact fraction, which is PIF, combined with work-related risk estimates for these three disorders from systematic reviews. The percentage of workers exceeding these risk estimates was based on worksite observation among 28 floor layers. For LBP, 16 by 18 workers were at risk when using traditional working techniques with a PAF of 38%, and for those using a manually movable street leveling machine, this was 6 by 10 with a PIF of 13%. For LRS, these data were 16 by 18 with a PAF of 55% and 14 by 18 with a PAF of 18%, and for KOA, 8 by 10 with PAF 35 and 2 by 10 with PIF is equals to 26. So a manually movable street leveling machine might have a significant impact on the prevention of this LBP, LRS, and KOA among floor layers in the Netherlands, and a health impact assessments are feasible approach for assessing health gains in an efficient way. This is another one, primordial and primary prevention of peri-implant diseases. Our systematic review and meta-analysis, it also shows that the primordial prevention is better than primary. So moving on to the MCQs. Number one, a public health initiative aims to reduce the incidence of lung cancer in a community. The program includes a variety of strategies: smoking, cessation efforts targeting at-risk individuals, regular screening for early detection of lung cancer, and support services for lung cancer patients, including rehab and palliative care. Each of these strategies is designed to address the disease at different stages of its development. Which of the following best describes the level of prevention involved in this public health initiative? A. Smoking cessation and environmental protection are examples of primary prevention, which focuses on preventing the onset of disease. B. Regular lung case screenings for high risk individuals represent secondary prevention, which aims at early detection and intervention. C. Rehab and palliative care for diagnosed lung cancer patients are examples of tertiary prevention aimed at improving quality of life and managing disease complications. D. The initiative includes all three levels of prevention. E. The focus of the initiative is purely on secondary prevention as it only involves screening and early detection.
D.
Yes, D is the correct answer. Two, in a tropical region with a high incidence of dengue, local health authorities have introduced a long-term community-based initiative to address the root causes of the disease. The program includes urban planning strategies to eliminate mosquito breeding sites, improvement in sanitation infrastructure, and community education programs aimed at changing social behaviors that will contribute to mosquito proliferation, such as improper waste disposal. The initiative focuses on creating an environment that reduces the risk factors for dengue transmission before they can occur. So which of the following best describes the approaches used in community initiatives to prevent dengue? Number A, the initiative is an example of primary prevention. Number B, the initiative represents a secondary prevention. C, the initiative exemplifies tertiary prevention. D, the initiative is an example of primordial prevention. Or E, the initiative represents primary prevention as it focuses on mosquito control and community awareness campaigns.
D.
Yes, D is the answer. Three, Dr. Allen is an epidemiologist working in our public health department. She is studying the impact of a new preventable intervention aimed at reducing the incidence of respiratory infections in a high-risk community. Dr. Allen is focusing on understanding how effective the intervention is in preventing new cases and reducing disease burden in population. She plans to use her findings to inform public health policies and resources allocation. One of the key metrics she will analyze is the prevention potential of intervention. So why is assessing the prevention potential of a public health intervention important in epidemiology? A, it helps in determining the effectiveness of treatment options for individuals after they develop the disease. B, it enables public health professionals to estimate the impact of an intervention on reducing future disease incidence, thereby optimizing resource allocation. C, it primarily focuses on identification of genetic factors that contribute to disease outbreaks. D, it provides a method for monitoring the public's awareness and knowledge of a disease, which can influence prevention efforts. E, it is used to measure how many people in a population are likely to develop immunity against a specific disease over time. B is the
C.
correct answer. Yes, B is the correct answer. 4. Dr. Palvasha is a public health researcher investigating the link between smoking and incidence of lung cancers in a large urban population. She collects data from a cohort of 10,000 individuals, of whom 2,000 are smokers and 8,000 are non-smokers, over a 5-year period. So, doctor observes that 120 of the smokers and 30 of the non-smokers develop lung cancer. To assess the impact of smoking on development of lung cancer, doctor describes the calculation of attributable risk for lung cancer in smokers. So, based on the information provided, how would doctor calculate the attributable risk of lung cancer in smokers, and what is its significance? A, attributable risk is calculated as the difference between overall lung cancer incidence rate in the population and the incidence rate in non-smokers, showing the total risk of disease in population. B, attributable risk is calculated by subtracting the incidence rate of lung cancer in non-smokers from the incidence rate in smokers, giving the extra risk of lung cancer due to smoking. C, attributable risk is the ratio of lung cancer cases in smokers to the total population, reflecting the proportion of the population at risk of developing the disease. D, attributable risk is calculated by dividing the number of lung cancer cases in non-smokers by the number of smokers to determine the impact of smoking on non-smokers. Attributable risk E, it is calculated by multiplying the incidence rate of lung cancer in smokers by the proportion of non-smokers in the population to estimate the total risk in population. Answer is B. 5. Dr. Maria is studying the relationship between high fat diet consumption and the incidence of the heart disease in a population of 5,000 adults. She tracks 2,000 individuals who consume a high fat diet and 3,000 individuals who follow a normal diet over a 10-year of time. Among the high-fat diet group, 150 individuals develop heart disease, while in normal diet group, 50 individuals develop heart disease, while incidence rate in high-fat group is 0.075 or 75%, and incidence rate in normal group diet is 0.0167. So Dr. Mai wants to calculate the attributable risk proportion to understand the proportion of heart disease cases in high-fat diet group and could be attributable to the high-fat diet. How should she calculate the attributable risk proportion? A, 77.7%, B, 49.2%, C, 36.7%, D, 67%, E, 89.3%. Answer is A, 77.7%. 6. Dr. Azam is an epidemiologist working on a study to evaluate the impact of air pollution on incidence of respiratory diseases in a metropolitan city. After analyzing the data, he finds the incidence of chronic respiratory diseases significantly higher in areas with high levels of air pollution. Dr. Azam is now interested in estimating the prevention potential. One of the key metrics will guide this estimation is attributable risk. Why is attributable risk an important measure in estimating the prevention potential? A, attributable risk helps determine the proportion of diseases cases that could be prevented if the risk factors were completely eliminated, providing an estimate of potential reduction in disease burden. B, attributable risk shows the total incidence rate of respiratory disease in population, irrespective of exposure, helping researchers compare disease across different populations. C, attributable risk is used to calculate the total healthcare cost associated with respiratory diseases, aiding in cost effectiveness analysis of interventions. D, attributable risk estimates the proportions of population that is exposed to air pollution, allowing researchers to focus on non-exposed individuals when design public health policies. E, attributable risk helps calculate the relative risk of developing respiratory diseases in exposed individuals, which is crucial for measuring disease severity rather than prevention. Correct answer is A. 7. Dr. Javed, a public health researcher studying the effectiveness of a new vaccine aimed at preventing a specific infectious disease. Clinical trials showed out 1,000 vaccinated individuals. Only 10 developed the disease, while in unvaccinated group of 1,000, 50 developed the disease. Dr. Javed wants to calculate the numbers needed to be treated to prevent further cases. While incidence in vaccinated group is 0.01, incidence in unvaccinated group is 0.05, absolute risk reduction is 0.04. Using above mentioned data, calculate NNT. A is 5, B 115, C 25, D 50, E 75.
A.
No, the correct answer is C. A. Dr. Ghazala is an epidemiologist studying the relationship between physical inactivity and the incidence of CVD in a large urban population. He observes that physical inactivity is a significant risk factor, now interested in understanding the impact fraction of cardiovascular diseases. So the impact fraction will help her quantify the proportion of the disease burden. Why is calculating impact fraction important in estimating the public health significance of physical inactivity in population? A, impact fraction measures the proportion of cardiovascular disease cases in the population that could be prevented if physical inactivity were eliminated, providing insight into the potential benefits of interventions. B, impact fraction is used to calculate the total number of individuals who are physically inactive, allowing researchers to estimate the prevalence of the risk factors in population. C, impact fraction helps estimate the cost effectiveness of interventions to reduce cardiovascular disease by quantifying the healthcare savings associated with reducing physical inactivity. D, impact fraction is used to identify the relative risk of developing cardiovascular disease in physically inactive individuals compared to those who are active. E, impact fraction estimates the proportion of cardiovascular diseases cases that are due to genetic factors, helping researchers focusing on interventions targeting genetic predisposition. So the correct answer is
A.
A, yes. 9. Dr. Tahir, an epidemiologist working with a public health team, estimates the prevention potential of a new vaccine for preventing specific infectious disease in a large population. So he's using a various modeling approaches to estimate how effective the vaccine might be at reducing disease burdens on population, including the number of cases, hospitalization, etc. Modeling approach chosen will help from public health strategies and guide resource allocation for vaccination campaigns. So he considers several modeling approaches. One of the key aim is to understand how many disease cases could be avoided if the vaccine is made available. So which modeling approach is most appropriate for estimating the prevention potential? A, cohort, B, case control, C, dynamic transmission, D, Markov, E, cross-sectional.
A.
D.
Yes, cohort is the right answer. 10. Dr. Afia is an epidemiologist working on a study to estimate the prevention potential of reducing tobacco use in population of smokers.